So good evening, everybody, and thank you for joining us for our next series of webinars from OCL Vision. My name is Ian Bradbury, and I will be your host for this evening. To all of you, those joined for the first time, a big welcome to you. And for the regulars, a huge thank you for coming back to us again. I would like to thank you all for the feedback. It's all very useful, and we do like hearing your feedback. And it's good to hear what you think about the webinars. As you know, things have changed, so they will know I will be no longer uploading CET directly to the GOC, but instead you will need a certificate stating you attended this webinar. We will send the certificates out to you. Please ensure you have registered with your correct name and GOC number, as this will be printed on your certificate. There is one CPD point for optometrists and dispensing opticians. This webinar is recorded and will be available to view along with our other webinars on our YouTube channel. This lecture will run for 45 minutes and there will be questions at the end. So if you have any questions, please enter them in the Q&A box at the end at the bottom of the screen, and I will read them out at the end. I am very excited to announce today's speaker, who is our new consultant at OCL Vision, Rabia Bourkiza. Sorry, I've got that wrong. She is a consultant ophthalmology surgeon at OCL who specializes in Vitreo-Retinal surgery, medical retina and cataract surgery, including complex cataracts and advanced lens implants. Her main NHS base is at the London North West University NHS Trust, where she has established a robust Vitreo-Retinal service, attracting referrals from other West London hospitals. Rabia, I'm excited to hear this, so I will now like to hand over to yourself.
Thank you very much, Ian, for the lovely introduction. Can you hear me okay?
I can hear you fine, yes.
Okay, good evening, everyone. Thank you very much for joining us today for Demystifying Retinal OCTs. So I chose the title today on the basis of requests from many optometrists to cover OCT teaching. And it was felt that AMD and CMO was covered a lot. And so we called it Beyond the Obvious. Not that I think that anything is obvious, because we often get co-pathologies and things become not so straightforward. And so my name is Rabia Bourkiza. I work at OCL Vision at a number of locations, 55 New Cavendish Street, Elstree, Spire East. My NHS base is at Central Middlesex Hospital in West London. So the objectives of today is to have a systematic approach to OCT, to be able to recognize structural changes and identify pathology, and therefore know when to refer and the appropriate urgency of referrals. So we're going to go through normal OCT, just a recap on the basics, and then we're going to cover vitreomacular interface disorders, and then retinal vascular disorders, and some other retinal pathology. If we get enough requests, I am pretty sure that we can't get through all the retinal pathologies. So if we get enough requests, we can cover a part 2 in another webinar very soon. So just back to the basics. Just before I start, actually, I will be asking some questions throughout the webinar. So please answer in the chat, and I'll be able to see your answers. And then at the end, we have the Q&A, which Ian will chair. So optical coherence tomography acquires basically cross-sectional images with semi-histological resolution. Is similar to ultrasound, but instead of sound waves, it uses light waves. So essentially you get lots of cross sections. If I can play this video. And so we look through the entire macular scans. So the image is produced by assessing the intensity of the reflected light. And we describe it in the same way as we describe color photographs as, hyperpigmented lesion or hyperpigmented lesion. We describe OCTs as hyperreflective structures that appear white, or hyperreflective structures that appear black. So essentially fluid will let the light through, and so it will appear black. And anything that is fibrous or a sheet, it will reflect the light back, and that would be hyperreflective. You will also get some gray structures, which are intermediate reflective structures. And so these are this is a normal OCT, essentially. So if we go from the inside out on the green arrow, we can see the vitreous. Vitreous is clear in the majority of the of patients, and therefore it doesn't reflect, so it will appear dark, so hyperreflective. We look at the fovea, and then which is essentially we look at all the anatomy of the fovea, and we go into that in more details. And then the blood vessels. And then the blood vessels essentially appear hyperreflective, as you can see here on the red arrows. And they cast these shadows in the outer retina. And this is basically called screening artifact from the blood vessels, not that there is any cyst in there or anything. And so that's how we identify blood vessels. And obviously you go deeper and you find the choroid. So this is the international classification, or sorry, international nomenclature of OCT, which basically came about in 2014. And it's a busy slide, but I'll go through things one by one. So let's get this out here. Sorry, this panel at the bottom here. And sorry, yeah. So we can see here the hyper-reflective layer here, which is the posterior cortical vitreous, or the posterior hyaloid phase, whatever you want to call it, but it is hyper-reflective. If you don't see it, it doesn't mean that it is detached or attached. You can't tell sometimes if it is attached to the retina, or if it is further detached from the retina, then you can't see it as well. So you can't tell whether there is a PVD or not unless you see it close to the retina. Yeah, okay. And so the next layer is the internal limiting membrane. The internal limiting membrane, we don't necessarily see it all through, but that's basically the innermost layer of the retina. Now, just to basically have a warm up on the chat, can I ask the audience, is this a right eye or left eye? Right, okay, we get lots of rights, so great, fantastic. So the way to tell is from the nerve fiber layer. So as you can see, the nerve fiber layer is thickest in the nasal part of the macula, so between the fovea and the optic nerve. And so the nerve fiber layer is a hyper-reflective layer that is formed by the axons of the ganglion cells. And we get swelling in ischemic events. You get swelling of the nerve fiber layer. And so this corresponds to the histology here. The next layer is the ganglion cell layer. So the ganglion cell layer is hyperreflective. So if you think about the anatomy of the retina, all the cells have cell bodies and have the axons. So the cell bodies will be hyperreflective. And that is because they absorb light rather than reflect it. And so the ganglion cell layer is hyperreflective, and it's the cell bodies of the ganglion cells. The next layer is hyperreflective. So you get two hyperreflective lines in the middle of the retina. So this is the first one, and you can follow it through the fovea and then on the other side of the fovea. So the inner plexiform layer is the synapses of the ganglion cell layers with the bipolar cells and the dendrites. And so this is hyperreflective, the inner plexiform layer. Then you get the inner nuclear layer, and these are the cell bodies of the bipolar cells and the molar cells and the horizontal cells and amacrine cells, and therefore it's hyporeflective, so inner nuclear layer. And we go deeper into the outer plexiform layer. Again, that's one of the two hyperreflective lines in the middle of the retina. And these are the synapses, or the interconnections between the bipolar cells and the photoreceptors. And this is hyperreflective. And then we go deeper again, and this is the hyporeflective layer here, which is the outer nuclear layer. The outer nuclear layer, these are the cell bodies, or the nucleus of the nuclei of the photoreceptors. In the middle here, in the middle of the fovea, or the central fovea, you get the Henle nerve fiber layer, and that is basically represents the cell bodies of the cones. So you get a little bit thicker on the Henle nerve fiber layer, and that's why when you get CMO, you get these high columns, and that's basically in the Henle nerve fiber layer. Okay, so we are finished with the inner retina. Now we go to the outer retina, and the outer retina has 4 distinct hyperreflective lines, so that you have to identify when you are assessing an OCT. So we start with the external limiting membrane. The external limiting membrane is essentially the junction between the cell bodies of the photoreceptors and the inner outer segment. And also is interjection with other cells like the Muller cells. So the external limiting membrane is the first layer of the outer retina, so it's hyperreflective, not very hyperreflective, but the first hyperreflective layer. And then deeper to that, we get into the myoid zone of the photoreceptors. So this is all based on the 2014 classification. So that's the newest classification of the OCT layers. So the myoid zone is the black layer that is just underneath the external limiting membrane. So it's the myoid portion of the inner segment of the photoreceptors. And then we get to...
Sorry, can you get a bit closer to the microphone? I think we've got some people that can't hear quite so well.
Okay. Can you hear me better now?
I can hear you better now, yes.
Okay, great. And so the other bright layer is the ellipsoid zone, and that's one of the most important layers that some people refer to as the IS-OS junction, and some people refer to it as the ellipsoid zone, and that's basically the outer segment, the inner segment, but this is the outer layer of the inner segment still of the photoreceptors. And as we go deeper, we go into the outer segments of the photoreceptors, and this is this dark layer here. So it's hypo-reflective. Recently has been referred to as photoreceptor layer 2. I don't think it should be, confused with anything. This is basically outer segment of the photoreceptors is dark, is deeper to the IS-OS junction or ellipsoid zone, whatever you want to call it. The next layer is the interdigitation zone, and that's between the outer segment and the RPE. It's a very thin hyper-reflective layer, or the inner, basically, layer of the RPE. And then we come to the RPE with Brooks complex, and that is the brightest, whitest, outermost layer. Okay, and usually it's not separated from Brooks in normal circumstances. So, and then we go deeper to the choroid. So you have the choriocapillaris, which is the just underneath the RPE, and then we have the subtler layer and the halo layer, and then the choroid scleral junction, and that is how we measure the choroidal thickness. We go from the RPE into the choroidal scleral junction. Now, in a nutshell, what you need to know when you are looking at an OCT is you look at the brightest, whitest, outermost line. That's how I approach it. And so basically that's the boundary between the retina and the choroid, and I look at the integrity of that. Then I look at the basically the other layers of the outer retina, starting from the external limiting membrane, the ellipsoid zone, or IS-OS junction, if you want to call it that. And then I look at the inner retina, so looking at all the layers of the inner retina. And then I go back and look again at the IS-OS junction, because that's basically what sometimes makes helps in the decision making. So we're going to start with macular interface disorders. So if you you'll see that I'll be starting from the inside out. So macular interface disorders, a spectrum of pathologies that depend on the degree of vitreous separation and specifically on the degree of vitreofoveal detachment. And so, sorry, let's go to the next slide. So if I can have some answers from you as to how do vitreomacular interface disorders present usually to your practice? If you can give me 3 things. Let's see. Flashes, floaters, we get floaters, flashes, lots of flashes and floaters. So we thinking here about the macular, vitreomacular interface rather than vitreoretinal interface, which is broader. So if we narrow it to the vitreomacular interface, how would patients present? Great, so distortion, we're starting to get a lot of distortion now. Brilliant, so we get floaters, flashes, distortion. So usually the patients, yeah, reduced vision, fantastic. So exactly that. So basically the most common presenting scenario is distortion or reduced vision or blurred vision generally if they go beyond the distortion or they don't actually perceive the distortion, and depending on their ocular dominance as well. And in a lot of patients is usually just asymptomatic. So they don't complain of anything, and you do the OCT or you look on the slit lamp biomicroscopy and you find something. So we're going to start with one of the very common vitreomacular interface disorders, which is epiretinal membrane, which is usually idiopathic, so many birthdays, or it could be secondary to previous laser or previous surgery or previous injury. Retinal breaks is very important to check for retinal breaks when you see an epiretinal membrane, or it could be also associated with retinal vascular disorders like diabetes, vein occlusions, etc. And so basically it's thought to be proliferation of RPE cells and glial cells, and the majority of patients with epiretinal membranes would have a PVD. So these are the OCT features of epiretinal membranes. You can see here a very bright hyper-reflective layer, which is the epiretinal membrane. Underneath it, you can see that the retina is thrown into many folds, particularly the inner retina. You can see here that this is the inner nuclear layer, the outer nuclear layer, the inner and outer plexiform, they're all folded. When you look at the outer retina, the external limiting membrane is continuous, smooth, it's not folded. The photoreceptors or ISO's junction is also nice and smooth. So these are, obviously the fact that the outer retina in this OCT is good is a good sign. However, the patient may still have distortion with this. And so general thickening of the retina, there is no dipping of the fovea with this. And so essentially this is the same patient 1 year apart. So the bottom picture is a year later. You can see that the hyper-reflective layer of the epiretinal membrane has got even thicker, and there is more folds in the retina, as you can see here, and there is more anterior posterior traction. So as you can see, that the outer nuclear layer, the outer plexiform layer is pulled up, and sometimes you can see some herniation through that epiretinal membrane. So you can see the striae here on the on-pass picture as well. So in addition to the anterior posterior traction, you get some tangential traction. So the traction will cause a pseudohole. And so essentially, this is an OCT picture of a pseudohole. You can see the epiretinal membrane here, a little bit discontinuous here. You can see it on the other side, hyper-reflective line. And you can see that there is a heaped edges or invaginated foveal edges. There is no loss of retinal tissue. So the retinal tissue is there, but it's just under tangential traction and some obviously anterior posterior traction. You look, when you see something like this, you always look at the outer retina, the external limiting membrane, which is this first hyper-reflective line of the outer retina, then the photoreceptor ISO's junction, and obviously the RPE, and they are intact. And so this is just to show the heaped edges. So what do we do about epiretinal membranes? We peel them, so we do vitrectomy. We put a blue dye in the epiretinal membrane, and that would help us peel the membrane across the macula. And so we normally do the surgery on the basis of symptoms. So if the patient is asymptomatic, we don't usually offer surgery. If the patient has distortion, the quality of life is improved by the reduction of distortion from the surgery, even if the visual acuity itself is not improved a lot. And so when we look at studies looking at the epiretinal membrane surgery outcomes from vitrectomy, we quote the 70% improvement after the surgery, with a mean vision of 2 lines gained, and 83% of patients would get an improvement in the distortion. And so basically, as a surgery, it actually works. So this is one of the conditions that, you know, if you see them in the community, and because they are basically prevalent, is basically 1 in 10 patients would have an ERM. If you see it in the community, you reassure the patients that the majority of epiretinal membranes will remain stable. If they are symptomatic, obviously you refer them, a routine referral, unless they have really bad quality of life with, say, bilateral ERM or an ERM in dominant eye, and they have a lot of distortion that they can't fuse. So if that's the case, then obviously we can see them sooner than a routine. Routine generally is about 3 months or so. But if the patient is really symptomatic and can't live with it, you can refer them sooner. But there's no urgency as such. And if the patient is asymptomatic, you educate them about the signs and symptoms of progression. You might want to give them an Amsler grid to self-test. And so basically I reassure them that there is a potentially successful surgical procedure for this. Okay, so that leads me into the next condition. So if I can back to questions now. So if I'm looking at the chat to see any spot diagnosis, please. Yeah, fantastic, brilliant. So yeah, without a doubt, vitreomacular traction. So fantastic. So vitreomacular traction syndrome, as you can see here on the left, you have a nice PVD. On the right, you have vitreous separation from the periphery, still stuck at the center. So basically, I want to tell you a bit about the International Vitreomacular Traction Study Group classification, which was in published in 2013. And on that basis, we classify macular holes as well. So we start with vitreomacular adhesion. So adhesion is when you have attachment of the vitreous, or you call it vitreous cortex or posterior hyalophase, within 3 millimeter radius of the fovea, as you can see here, with separation either side. But the retinal structures are all normal, so you call it VMA, and it's subclassified into focal, which is less than 1500 microns, or broad, and you can have it isolated or concurrent with other pathology. So you could have here a broad vitreomacular adhesion. So as you can see, there's separation here beyond these 2 arrows, and everything is adhered within the fovea. Again, that's VMA because all the layers of the retina are absolutely fine. So the difference with VMT from VMA to VMT is that you have interruption of the retinal layers. So essentially you get intraretinal cysts, or you get outer retinal changes, and we come into that in a second on the grading of the symptomatic VMT based on OCT. So grade 1 is when you have thickening only, as you can see through this wide field OCT. You can see the separation here, but then there's adhesion all along here. And you know, this is a broad VMT because you can see here from the diameter of the optic nerve, this is much wider, so it's more than 1500 microns. So this is thickening only, there's no cyst. Grade 2 is when you have intraretinal cysts or pseudocysts, whatever you want to call them. Basically, there is a space in the inner retina with the vitreomacular traction, and that is grade 2. You look at the outer layers, so the ellipsoid zone or the ISOS junction, and it's intact, and that's what makes it grade 2 versus grade 3. So grade 3 is when you have separation of the retina from the RPE. As you can see here, there are lots of intraretinal cysts. There is disruption of the ISOS junction here. You can't see where it's going, and you have outer retinal pockets as well. So essentially, this is a grade 3 VMT. This is just to show you just a broad one of VMT with epiretinal membrane. This is another image of focal VMT. And this is a grade 2 because you have a focal because it's less than 1500. You have an intraretinal cyst, and the ISOS junction is normal, external limiting membrane is normal, and the RP is normal. So this is a grade 2. You can have it concurrently with other conditions, particularly with diabetes. You get more adherent posterior hyaloid face in diabetic patients. So you can see here that you can see exudates, hyper-reflective dots. We'll go into that later as well, but you can see that there is this multiple points of adhesion. And generally when these patients are referred to me, they are referred because of sometimes lack of response to anti-VEGF with DMO, and they have VMT, and so I perform vitrectomy on them, and we usually see that there is improvement in the retinal thickness and in the response to the anti-VEGF treatment. So if we leave VMT alone, so up to between 30 and 50% will spontaneously release within 1 to 2 years. So the question is, do we wait or do we go and intervene? And so the studies have shown that the higher grade of the VMT, you have a higher chance of spontaneous resolution. Spontaneous resolution in this context doesn't mean that you have better vision. It just means that the vitreous will separate from the retina. Then you have a high risk of worsening into a full thickness macular hole, the vision worsening, etc. And so we do want patients that have vitreomacular traction with subretinal fluid, that they have a more guarded prognosis. So even with intervention, you have a more guarded prognosis. So if we see SRF with VMT, we're more likely to intervene, and we give them that guarded prognosis. We do not wait usually with broad VMT, particularly when there is outer retinal changes, because essentially it's unlikely that it will separate. And usually, you know, patients may be a bit hesitant, and we wait for a few months, and then they come back again and they see that it's exactly the same or even worse, and they are more aware of their symptoms, and that's when we usually intervene. So in a nutshell, if you leave VMT alone, that's what we tell the patients, up to a half may spontaneously improve. However, those that don't improve, up to two-thirds may lose 2 lines or more. So the higher grade of the VMT, the worse the outcomes. So you can see here, this is a patient from some time ago, actually, and it was observed because the patient didn't want to have surgery. So you can see that there is the VMT here. All the layers are disrupted. You can see, I mean, this is an old image, but you can see that this is the RPE, the brightest layer, and then just above it, this is the photoreceptor or ISOS junction, which is disrupted. You can't see it at the foveal, in the fovea. And so a few months later, it's spontaneously released. However, it left the patient with a full thickness macular hole and with a focal detachment underneath it. And so because of this progression into macular holes, we do tend to intervene early with these patients. So as you can see, this is the same patient. Right eye had a full PVD with a full thickness macular hole, and the left eye has a VMT with VMT grade 2 with some intraretinal cysts. The outer retinal layers are absolutely fine. However, we would have a low threshold for intervening in this patient because the other eye had macular holes. So it would be most likely go in the same way if we leave it. And so this is the same patient I was showing you in the previous slide on the right eye. And so you can see here that there is a VMT with intraretinal cysts, and then it progressed, and it progressed a few months later. And then when the vitreous has released, it led to a full thickness macular hole. As you can see, the only layer that you can see here is the RPE. So the photoreceptors are all gone sideways. So indication for surgery, like any other vitreomacular interface disorder, reduction in vision, distortion, double vision, and if they have failure of fusion. If the patient comes to you and says, you know, I have to close the eye close the eye for me to read with the other eye, then that is an indication for surgery. And so why do we treat VMT? Why do we do vitrectomy? There's a big meta-analysis that was done by Tim Jackson a few years ago, and that showed that 2/3 of patients improved after the vitrectomy for VMT, and 1/3 gained more than 2 lines of vision. Obviously, there are some risks with cataracts and development of epiretinal membrane. In some cases, if you see that there is a high chance that they will develop an epiretinal membrane because they developed in the other eye, you can also peel the internal limiting membrane to prevent that from happening. And you can combine it with cataract surgery as well. So in the community, if the patient is symptomatic, refer them so long as they accept the 1% risk of retinal detachment. And that happens with any vitreoretinal surgery. If they are asymptomatic, and they had macular hole in the other eye, you would still refer them because they would be at a higher risk of developing a macular hole. If the patients are completely asymptomatic with good vision, then you can observe them in the community and you educate them about the signs and symptoms of progression. And so that leads me into macular holes. This is just an OCT image. I just like the high resolution of it. So you can see the posterior hyaloid face and how it's tugging onto the fovea. So this is an operculum that is still attached to the posterior hyaloid face, and you can see that the only layer that you can see here is the RPE, the brightest, outermost, whitest layer of the retina. And so when we measure the smallest aperture, so basically from here to here, and we can measure the base of the macular hole. I'll come to that in a second. So in the past, we used to classify macular holes according to the GAS classification, but now we classify them on the basis of the International VMT Study Group classification, which also classified the VMT. So we have 3 factors. One is the size, so small is less than 250 microns, medium is 250 to 400, and large is more than 400 microns. The reason for this classification is because it has an impact on the prognosis. And so large holes, more than 400 or more than 600, they have a less chance of closing. And they usually, the larger the holes, probably the longer they have been in the eye. And also it classifies them according to primary or secondary causes. We know that secondary macular holes, secondary to retinal detachments or secondary to trauma or any other cause are less likely to close. And the third factor is the presence or absence of VMT. So if the vitreous is still attached or detached. So if it's already detached, and usually the hole is flat, it also has less chance of closing or improving in vision or the distortion. So as you can see here, what I was talking about in terms of measuring the aperture, we measure the smallest aperture in this macular hole. We also measure the base, and then basically this is mainly for audit purposes and also to give a prognosis to the patient. So this is the same patient. This is what we do for macular holes. So essentially, again, we use the blue dye, but this time is to stain ILM. We peel ERM if there is a concurrent ERM as well. And then we put a gas bubble in the eye. And there is more than 90% chance of closure with that. So this is an image of a small macular hole. As you can see here, the very small aperture, less than 250 microns. This was managed with a vitrectomy and ILM peel. This is a 4 week after the surgery. You can see that there is still some intraretinal cysts, but it closed, which is a success. If you follow them over time, so I think this was 6 months down the line, and you can see that it's fully closed. It's not always as smooth, and you can't get the foveal dip again. However, you get that closure, you reassure the patient that, you know, at least you stabilize their vision, you improve their distortion, you may improve their vision by a couple of lines. And so this is the patient essentially that I'm going to show you next. So this is the image after the vitrectomy. So you can see that it closed. However, you can see when you follow this, this is the RPE, brightest, outermost, whitest layer. The layer that is just above it is the ISOS junction. You can follow it, is nicely smooth here. However, it goes and it's disrupted and it's lost at the center of the fovea. So you can get closure with disruption and loss of the ISOS junction. So you don't always get, you know, all the layers back in. Also, over time, when you follow them, you can see that there is thinning of the retinal layers where, you know, after it closes. And so, just in a nutshell, more than 90% close, most improved 2 or 3 lines of Snellen visual acuity, and more importantly, they improve in the distortion, more than 70% improvement in the distortion. So that basically brings me into the next condition, which is similar. And I just to see that you are still following. So we're going back to the chat and looking at spot diagnosis of this. Great, fantastic. Everyone is on fire today. So laminar hole, fantastic, brilliant. Everyone agrees. So laminar hole. This is another image. I'm just going to go into the features of laminar holes. So essentially, you get this cavitation of the inner retina. You get ellipsoid or, you know, ISOS junction defect. So as you can see here, if we start following the ISOS junction from here, we follow it up to there, and then we kind of loosen it. We can't see the ISOS junction all along here, and then it comes back again. And also you lose the depth of the floor of the fovea, and you get this, what we call an epiretinal proliferation. This is not an epiretinal membrane. As you can see, it's smooth, is hyperreflective, and hyperreflective, then hyporeflective. You can see it on this side as well. So this is called epiretinal proliferation, and this is a hallmark of lamellar hole. And so I just wanted to show you, because we talked about pseudo holes earlier, and usually the confusion is between pseudo holes and lamellar holes, and, you know, are they the same? Are they different? Do we actually manage them in the same way? So I just wanted to show you some pictures. The pictures on the left of the screen are lamellar holes. As you can see, there is cavitation of the inner retina. There's a loss of the floor depth of the fovea, and there's epiretinal proliferation, which may or may not be present, but the presence of it tells you that this is more of a lamellar hole. When you look at pseudo hole, there is usually tractional elements. So there is epiretinal membrane. There is no loss of tissue, because if you iron this out, it will just be the foveal dip. And you can see that there is some cyst here on this image. However, there is no loss. There's no cavitation like there is on this lamellar hole. And so there is also, because of the confusion, there is a new nomenclature in recent studies in the last 5 to 6 years. So they have renamed them as degenerative lamellar hole and tractional lamellar hole. So tractional lamellar hole is basically a pseudo hole, and degenerative lamellar hole is what used to be called the lamellar hole. So lamellar hole, degenerative, so you lose tissue, cavitation, ellipsoid defect, and you can imagine that there is a top hat in that space. So this was actually presented a few years ago at Retina. So this is a top hat configuration when you're looking at the OCT. Tractional lamellar hole or a pseudo hole, you have this epiretinal membrane. You can see the the waviness under the epiretinal membrane, and you can see that the ellipsoid zone here is intact, and is actually, there is no loss of foveal tissue, and you have these cystoid spaces, but it's not loss of tissue, and you can imagine that there is a moustache in there. So this is kind of a way of remembering top hat versus moustache, tractional element, no tractional element, and this makes a difference into the management, because when it comes to us, do we actually operate or not? So for personally, if there is a tractional element, and this is based on the studies that have been done, because there's still some controversy as to whether to operate or not. So if there is a tractional element, I would operate vitrectomy, epiretinal membrane peel, ILM peel. I may or may not put a gas bubble. If there is a tractional element, but there is an ellipsoid defect, then it depends on how much of an ellipsoid defect. It depends on how much symptoms the patient has, and I may consider vitrectomy for that. If there is no traction and the ellipsoid, and there is a clear-cut ellipsoid defect, then I wouldn't operate. You can still find some patients, some surgeons that still operate on degenerative lamellar holes. The studies have shown that there are poor outcomes with those, and that's what I tell the patients. Usually the ones that have reported good outcome are those that have combined them with cataract surgery, and usually the improvement is from the cataract surgery, not from the vitrectomy itself. So now we looked at the vitreomacular interface. Now we're moving into the inner retina. So chat time, and what's the pink arrow? I'm waiting for some answers. Fibrosis, NVE, new vessel, CMV, vitreous stuff, cottonwood spot. So we have lots of okay. We have lots of suggestions. So yes, so basically one of the most important messages are that we have to interpret the OCT in the context of the clinical picture. So here we have an NVE. This is a diabetic patient. You can see that there is this hyper-reflective material that is just above the ILM. There is a posterior hyaloid face is here. So it's between the posterior hyaloid face and the internal limiting membrane. And so this is likely to be a new vessel. So this is a new vessel. If you look at the image of this patient, you can see that there is a new vessel here. It is very helpful when you are not sure whether this is IRMA or new vessel to do an OCT and see if it is elevated, and that's when you can confirm that this is a new vessel. So this is another picture of a new vessel elsewhere. As you can see on the color picture here, infratemporally, you can see some fibrosis with a new vessel here, and you can see that it's migrated into the posterior hyaloid face, and they usually grow tangentially into the posterior hyaloid. Now, this is a pre-retinal hemorrhage where this is a diabetic patient. Most likely that they've had new vessels at the disc or elsewhere, and they bled through. So when we look at the OCT image through that, usually we get a hyper-reflective material that is all along the inner side of the retina. Sometimes we don't see, this is ILM, but sometimes we don't see ILM, and we are not sure sometimes when there is a bleed whether there's subhyaloid or sub-ILM. Usually it's subhyaloid in diabetic patients, but not always. But it doesn't really change the management that much, because we still intervene. So this is another feature of diabetic retinopathy. So we can see here that there is a hyper reflective nodular and elongated lesion in the inner retina, usually in the nerve fiber layer and the ganglion cell layer, and that is basically cottonwool spots. So cottonwool spots are due to the axonal stasis and basically infarction. So this is so this is infarction of the nerve fiber layer, and it usually clears, but it takes up to more than 6 months actually. And sometimes when the patient has just an isolated cottonwool spot and you're not sure is this patient diabetic or not diabetic, it might be the first presentation, and OCT might help with that. And so I was going to go to the chat, but I think this is I've been getting good answers for all the questions that I've asked so far, so I'm going to skip that. And so essentially you have this hyper reflective lesion here, which is in the inner retina. If you remember at the beginning of the webinar, we talked about blood vessels and blood and how it casts a shadow, and you have this screening effect on the OCT. So this is blood, so this is a microaneurysm. So this is a microaneurysm, and there is no associated macular edema. Incidentally, there is a PVD with it as well. So it's hyper reflective. This is the same patient a few months later, and you can see that with this microaneurysm, there are some intraretinal cysts, so hyper reflective. So this is intraretinal fluid. And you can see that there is more. Now you can see exudates as well, and you can see that there is the cavity of the lumen of the microaneurysm here, in addition to more edema. So exudates appear as very hyper-reflective. They can appear anywhere, and they are sometimes next to the microaneurysm. Sometimes you can see them in a different layer to the microaneurysm. So this is an intraretinal cyst. This is intraretinal fluid. These are exudates. And so when you have gross macular diabetic maculopathy, you get all sorts. So you get exudates, hyper-reflective, is yellow arrow. You get microaneurysms with the lumen inside, and then you have lots of intraretinal cysts. And as I said, here it casts a shadow. So if you're looking at this and you think this is discontinuous, it's not because there's disruption of the photoreceptors or the RPE necessarily. And so when you have diffuse macular edema, what you see is generalized thinning of the retina. So this is the later stages of diabetic maculopathy, and you can see it on the map here as a blue map. And so in terms of treatment, how we treat it is based on the NICE guidelines on the NHS. So we look at the central zone. Some units look at the central zone number 1. Some units take from 1 to 5 into consideration, because the NICE didn't specify that this is the central subfield that we have to go by, and it's the central retinal thickness. And so if you look at this patient here with diabetic macular edema, and they have intraretinal cyst, they have microaneurysm, but their central retinal thickness is 300 microns, they wouldn't qualify for an anti-VEGF. So this is the same patient on the right eye. I'm going to show you the left eye. And so the left eye, you can see that there is more thickening. It's nearly 500 with similar features. You have exudates everywhere. You have intraretinal fluid, both in the inner retina and the outer retina, and this would qualify for anti-VEGF. So this patient here, they appear with a lot of exudates and cottonwool spots and microaneurysms and hemorrhages. This is how they present, with more than 400 microns in both eyes, and they have disruption through all the layers. So you have intraretinal cysts, you have exudates, you have subretinal fluid here. As you can see, when you are following the ISOS junction or ellipsoid zone, is actually detached from the RPE. And that's because there's a lot of edema. So this is after a lot of injections, and the macular thickness has improved dramatically, and the vision has improved as well. So as you can see, they go from 0.9 to 0.7 on the right eye. So still within the retinovascular disorders, vein occlusions with cystoid macular edema. I'm aware that Shani has addressed vein occlusions in a recent webinar, but this is just to draw your attention to similar changes in the OCT with cystoid macular edema. You get these elongated cysts. That's because the Henle nerve fiber layer is more affected, and you get some smaller cysts as well in the inner retina. Usually with these, you refer the patient soon because we are worried about them turning ischemic and then having rubeosis afterwards. So we would see them monthly. So you would refer them soon, but also because they would want to receive some anti-VEGF therapy for the macular edema, which is one of the most common causes for the visual deterioration. So the same thing with branch retinal vein occlusion. You have similar features, so intraretinal cysts, subretinal fluid, if it is a bad macular edema, and usually it responds nicely with branch retinal vein occlusion to anti-VEGF. And so this is a hemiretinal vein occlusion. So the change, the only difference from branch retinal vein occlusion is that you get another quadrant that is affected. So you look at the nasal retina. But it's basically the same principles. You get intraretinal fluid, you can get subretinal fluid, so you can get this, you know, the subretinal fluid, because you can see that this is the RPE, this is the ISOS junction, and it is detached. You can also see some exudates. The exudates may not be apparent clinically because there's a lot of hemorrhages, etc. So you may not see them. And so you can also get new vessels, as you have rightly identified earlier. These new vessels, you can see them because sometimes you are not sure whether these are new vessels or they are collaterals. New vessels are usually finer, and you can also depict them with the OCT, either at the level of the disc or elsewhere. Macular branch vein occlusion usually affects just the macula. As you can see here, it affected it with intraretinal cyst and subretinal fluid as well. And usually the vision is affected with these massively. When we think about the arteries, they usually cause more ischemia. So you get branch retinal artery occlusion where you get a lot of thinning. So when you look on the central macula, the central macula is of a normal thickness. When you go to the inferior macula and you take a scan through it, you can see that generalized thinning, and that generalized thinning is of the inner retina because there is ischemia. And central retinal artery occlusion obviously causes a dramatic reduction in the vision, and also with time you will see that there is a thinning, as you can see on the map blue. This was just an incidental finding of a PED, and I wanted to keep it here because I wanted to show that, you know, sometimes you just find some incidental findings and they're absolutely fine in the context of this condition, obviously. So, so basically, this is a nutshell of retinal vascular disorders and when to refer. So I'm just going to go through. I'm quite aware of the time, so I'm going to spend the next few minutes talking about some other conditions very briefly. And so I just wanted to show you this and see whether we have some spot diagnoses as to what the condition is. Fantastic, brilliant, brilliant. Wow, I'm actually impressed. So that was you know, an overwhelming majority that said that it's a MacTel. So rightly so. Where am I? Yes. So with MacTel, what you get this blunting of the foveal contour. So the foveal contour usually is more kind of dipped than this. This is more kind of blunted. And you get these hyperreflective cysts, usually at the temporal side of the fovea, and you get disruption of the ISO's junction, as you can see here. So the RPE is nice and brightest, whitest, outermost, and then the ISO's junction or ellipsoid zone is disrupted. And so basically, McTell type 2 is an acquired condition, affects people in the 60s, usually more male, and is usually both eyes. So when you think about McTell 2, is both eyes, and you get these kind of mottlin or hypopigmentation that is temporal to the fovea. There's no proven treatment, and we don't know why it happens actually. But what is important is when patients are referred and when we see them, you know, sometimes they have other pathologies. So for example, they have vitreomacular retraction, or you know, they might have lamellar hole or things like that, and they expect to have treatment. And it's very important to counsel the patient, to let them know that, you know, at the moment there is nothing that can be offered, unfortunately, for this, but obviously treat any co-pathology with it. So this is the other eye. I showed you the right eye. This is the left eye. You can see similar findings, disruption of the ISO's junction, these inner retinal cysts, and you can see this blunting less so than the other eye of the foveal contour. Let's see, this is probably the second to last condition, so we're nearly there. I just want a spot diagnosis of this because we probably not a lot of people see this all the time. Central retinal artery occlusion, vascular occlusion, artery occlusion. So we're going into the artery occlusion territory. So this is actually a normal OCT of patients with sickle cell. And so in Northwest London, we have one of the highest prevalence of sickle cell in the country, actually. And I see this quite a lot. So because I see a lot of patients with sickle cell, I see this quite a lot, and this is normal variation. So what you see is temporal, in the temporal retina is all thinned out, but it's normal anatomy. So there is normal outer retina, and there is normal structure of the inner retina, but it's all thinner. And usually it doesn't happen in the nasal macula. It's all in the temporal macula. And so, sorry, let me just see. Good vision. It doesn't affect the vision at all. It doesn't need to be referred. Obviously, when you have a patient with sickle, you have to look for any proliferation, any active sickle cell retinopathy, because that has to be treated or closely monitored, I should say. So this patient, for example, had good vision since childhood, no problem at all. But when you look at the map, it's all blue in the periphery, and a lot of the patients are like this. This is I think this is the last one. So this is the last spot diagnosis, which is an introduction into part 2 of this webinar. Yeah, fantastic. So we have PED, CSR, overwhelming. I think we should, yeah, that's brilliant. So we have PED, as you can see, this is the Brooks, so you can see it here. This is the RPE, it's all detached. And you see that the ISO's junction is detached, so the retina is detached. So this is subretinal fluid. One tip I would say when we're looking at an OCT of this condition, which is CSCR, so central serous chorioretinopathy, is to always look at the disc. So always also get an OCT image of the optic nerve, because you want to know that there isn't an optic disc pit. And that's because the management is different. So if you have an optic disc pit and the patient is symptomatic, and we can cover that in part 2, the patient is symptomatic, you can offer them surgery. However, with CSCR, we do not offer surgery for. So always look at the disc and to make sure that there is no connection of this subretinal fluid to a possible optic disc pit. And so, CSCR, very common in young male patients, and usually stress brings it up. some people might be using steroids in any form, and we always ask about that. And it has been proven that if you reduce the consumption of steroids, whether it's cream or whether it's spray, it does actually have an effect on the CSR. There have been a number of things that have been tried, like beta blockers, aspirin, anti-VEGF, without good result. But the important thing to remember about CSR is in the acute phase, you can reassure the patients, because they need a lot of reassurance, that about 90% of the cases will have a spontaneous resolution within 6 months. Yes, it can recur, and usually the patients present with a hyperopic shift, and they are quite scared about it. But then if you reassure them, if you look into their steroid use and you give them some advice with regards to that and to their lifestyle advice, you can have good response. I just wanted to mention briefly about epinol, because it has been used and it has been like a buzz in the last few years, but there has been a trial that showed that there was no effect on the final outcome of vision. And so, you know, some people are using it, some people don't. Subthreshold laser has been used. PDT is used as well, particularly with chronic CSR. We're not talking about the acute CSR. With acute CSR, we just observe. Chronic CSR recurrent, we may try PDT treatment for that. And so if we get enough demand for a part 2, I'll be covering retinoschisis, myopic foveoschisis, optic disc maculopathy, adult vitelliform, and AMD. And so we will leave it at that for now. And the take-home message from today is always to interpret the OCT image in the context of the clinical picture and identify when it's significant pathology that needs a referral or that needs observing, and how urgent or routine. Thank you very much for being here today, and I will be more than happy to take any question you might have. And so over to you, Ian.
Thank you very much, Rabia, for that. That was so interesting. I've made quite a few notes, and I've missed half it because I was writing down, but that was so interesting. So thank you so much. And I will be looking forward to the next installment. So we have got a few questions, if that's okay. I could
absolutely
to you. So what sort of visual outcome after surgery for closing macular hole do you expect?
So usually, in real practice, when I audit my results, it's more than 93–94%. It's in the region of between 94–95%. But this is purely on idiopathic macular holes. So you have a very high percentage. The ones that do not close, we kind of know beforehand that they are less likely to close, and we counsel the patient with regards to that. So usually patients who have more than 1,000 microns, patients who have had this macular hole for more than a year. We also know that patients of Afro-Caribbean origin also have less chance of closure, and we do not know why. And so, yeah, so these are the main factors that we counsel the patient. But the idiopathic macular hole, less than a year, less than 600, you would expect about 95%.
So what's the urgency of referral from macular hole if you're seen in community?
So macular holes, they didn't used to be thought of as urgent. If you think about it, you know, probably 20–30 years ago, nothing was done. I think more than 30 years ago, nothing was done about macular holes. And gradually we are learning a bit more about them. And we know now that the earlier we do them, the better chance of closing and the better chance of improvement of the vision and the better chance of improvement of distortion. So I wouldn't say it is urgent. However, I would do it soon. It depends on the NHS trust, obviously. If we're talking about NHS, there are some NHS trusts that have more than probably about 6-month wait for vitrectomy surgery, and some have a 1-month wait. So I'm in the process of establishing this study on early intervention for full thickness macular hole, idiopathic macular hole, which I will get in touch with a lot of optometrists about in Northwest London. That would be interesting to see the results of that. But the earlier the better. That's what I would advise. If it was my eye, I would want it to be fixed as soon as possible.
Yeah. So how would you differentiate between a microaneurysm and an RAP?
Sorry, say that again. A microaneurysm
and an RAP.
And a RAP. There are many other features, basically. So with the microaneurysm, you basically take it in the context of the clinical picture. So with a microaneurysm, you usually have the patient might be diabetic, or sometimes we see it in like random microaneurysm. But with a RAP, you usually see this hyper reflective blood that is coming from the RPE all along into the inner retina. So the context is kind of different. The clinical context is different. So if I were to look purely at an OCT image and they give me like a big microaneurysm and a RAP next to it, I might not be able to, differentiate. But if I take, look at the other eye, the history of the patient, and also the examination of the peripheral retina and everything into context, then obviously we would make the differentiation. And sometimes obviously we have to do a fluorescein angiogram to differentiate.
Yeah. So what macular thickness would you consider anti-VEGF?
For DMO or?
It doesn't say. So I'm assuming, yeah.
Yeah, so basically with NICE guidelines, if we're talking about the NHS NICE guidelines, is 400 central macular thickness, and this has been interpreted by different units differently. So some units in the country take the very central zone number 1. And some units, so for example, Central Middlesex, we take anything from 1 to 5. So if we do a line across any of those and we find 400 in any of those, then we offer the treatment. For if we're talking about vein occlusions, then there's no it's not by thickness of the macula.
So with a VMT with no symptoms, should you refer?
If there is a VMT with no symptoms at all, you tell the patient that this is what you've got, and you tell them about what to expect if they were to have symptoms like distortion or blurred vision. And at that point, when they become symptomatic, then you can refer them. If it is a VMT grade 1 or even grade 2, I wouldn't refer. Definitely grade 3, usually they are symptomatic, unless they go beyond the distortion, because at the beginning they might have distortion in their non-dominant eye and they are not aware of it. And then when they get worse, they become more blurry rather than distorted. And at that point they have blurred vision and they are not perceiving the distortion.
Yeah, thank you very much. So how is it possible for a repaired macular hole to open again?
It's very, very, very rare for a closed macular hole to open again. Very rare. I don't think I've seen one. I don't think.
Yeah.
But surely it must have happened. But I don't think I have seen one. And I've seen lots of macular holes.
If there is a gap between the retina and the vitreous, and you don't have a previous OCT image, how would you know if it's physiological, such as a separation between the retina and the posterior hyaloid face, or a PVD?
So that the separation, so basically you can, I'm not sure I understand the question, because if you haven't seen the patient before and you don't know, and you don't have a separation, you say, and you don't know whether there's been a PVD or not. Is that, did I understand that correctly?
Yes, that's, I think.
Yeah, I mean, you wouldn't know, because it could be that the patient has had a PVD, and it's above the limit of the image. You can't see it, or that the vitreous is still attached to the retina, and you can't see that separation, and so you wouldn't know. So you would know clinically. If you see the posterior hyalid face, you see that, you know, the waves on the slit lamp microscopy, or if you see a Weiss ring, obviously, then you would know that there has been a PVD. But there's no way of knowing.
So should we just refer as CSR?
Absolutely, I think CSR should be referred, and mainly for because the patients are usually very anxious, and that's usually associated with it. So they are type A personality. They would benefit from reassurance, number one. Number two, the rationale of referring is so that you can see between the time that you see them in the community and the time that they get seen in the hospital, whether it got better or it got worse. And so yes, definitely.
Thank you. So would you advise more regular monitoring of an ERM, or just ask the patient to return if they get any changes with symptoms on AMSLA?
I think because epiretinal membrane is very common, as I said, 1 in 10 people would have an ERM. I would happily, like in the community, I would happily educate the patient about it. I'll say, usually what I say to the patients is that you have a wrinkly membrane at the back of the eye. It's like wrinkly skin. Obviously examine their peripheral retina, make sure that they don't have a retinal tear or a chronic retinal detachment. And then you can educate them about it and say it's a wrinkly skin at the back of the eye associated with age. If you see distortion, then, you know, come back to see me. If there's no distortion, then, you know, the majority of them remain stable for a long time. And so reassurance and educate them about the potential symptoms. So I normally tell them, I don't necessarily give them AMSA grid. If you want to give them an AMSA grid, or they download it from the internet, or you can just tell them, you know, once a week, you cover one eye, look at the window, look at the fridge. Is it distorted? Is it straight? Straight, you leave it alone. If it's distorted, you come back to see me.
So is there a level of VA that you would recommend that optoms refer in with the epiretinal?
So this is a good question, because it comes to a gray area where it becomes, you know, they don't have distortion. Could it be that they've gone beyond it and they are now all blurred, that they don't perceive the distortion? And sometimes they have a cataract as well, so it adds to that blurriness. And so I would say if they have, you know, say vision of 612, 6.9, 6.12, I don't have a cutoff, to be honest. I have operated on a range of patients with epiretinal membrane. I usually go by the symptoms. If the patient is symptomatic, as in they tell you I have blurred vision or I have distortion, then I would operate on them. If they are happy with their vision, you know, they can have 6.12 and they are happy, then I wouldn't necessarily operate. I'll give them the option, but I wouldn't necessarily, you know, sway them one way or another. So I don't have a cutoff vision, and I have operated on patients with 6.6 vision. But, you know, usually you look at their near vision. If it is more affected, usually it's more affected with epiretinal membrane, and also about the distortion as well. So I've had some patients with 6.6 minus vision and distortion, and I have operated on them with good results. The earlier, you know, like the better the vision to start with, the better the outcome.
Mm-hmm. So a question from an orthoptist. So many clinics are now carried out virtually. If an ERM is incidentally seen on the OCT, and knowing it can be indicative of an RD, should we be bringing them in for a face-to-face appointment?
If they haven't been seen recently, then yes. If it is a new finding, then yes, absolutely. Because if, say, you've never seen the patient, and for whatever reason, in the last 3-4 weeks, I've operated on 3 patients that were less than 40 years old with an epiretinal membrane. And it's a bit unusual, but it's like buses, they come in threes. So the reason, so one of them had peripheral retinal changes, so possibly an old tear. The other one looked like they had a vascular occlusion, and they are young, so they need to be investigated as well. So what I'm trying to say is that if you have, a known patient who's had an epiretinal membrane before, it was noted before, then I would just leave it alone. If this is a new finding, this patient, wasn't seen for a long time or was never seen, and they have an epiretinal membrane, then I would examine them at least once, just to make sure that they don't have anything.
Yeah. I have stood in tonight for Perry, who's not available, and there's loads of questions, and I think I'm going to have to limit the questions I'm going to read out. So if your question is not read out, I am so sorry. But
you've got my email address here.
Yeah.
I'd be more than happy to answer anything. Rabia at OCLvision.com. If you have any pressing questions, I would be more than happy to answer those. If you have specific topics that you want covered in the next few months, then please do let Pervy know, and I'd be more than happy to cover them.
I hope that Pervy will be back next time to introduce your next webinar. I'll read out a couple more questions if you've got the time. You've got the time for these, yeah? So,
sure, yeah.
In darker skinned individuals, often Indian, in the peripheral retina, there's often pigment change with distinct wavy border between the brighter and the darker retina.
Yeah.
Pathological, but just wondering what this is. Thank you.
It's we do not know exactly why it happens, but this is like white without pressure. It's basically similar to that. So you have the you have hypopigmentation in the very far periphery, and I do see that quite a lot in patients of Afro-Caribbean and Asian origin, and it's basically just a normal variation. It's possibly less, it's just less pigment in the periphery.
Thank you. So a question I think I'm quite interested in is, if we see a PED with no SRF and are asymptomatic, can we just monitor, and if so, how often?
And so PED, isolated PED, no SRF, I would probably see it initially. I would see it maybe in 4 months or 6 months. However, I would be relying on the patient's symptoms and the patient's pickup of the symptoms. So I would give an AMSA grid for that. And I would tell them clearly that if you have a sudden onset of distortion, then I would want to see you straight away. Mm-hmm. But yeah, so any interval is fine, because essentially they could develop something. Say if you see them in 2 weeks, they could develop that thing one day after 2 weeks. Or if you see them in 2 months, they could develop something one day after 2 months. So the key here, and that's what I do with my patients, is that I tell them exactly what to look out for. And in this case, I'd give them an AMSA grid and say, come straight away. If I see that they may not be reliable, then I'd bring them, soon and look at it again.
Thank you so much for that. I'm going to launch a poll now for the people that are still on. A poll that I don't normally do on my group, but I will start doing. But I'm just going to launch this poll. Hopefully it will come up if I press now. If you could just answer the questions, and then that will give feedback to OCL Vision, if you can see that there. I'll leave that for a few minutes, and then I'll take that down. And it's been a really thoroughly enjoyable webinar. So thank you so much. There's so much that I've learned, and I work in a hospital, and I've made so many little notes here that I think I didn't know that, and I feel I should have done. So thank you so much. It's been really worthwhile.
It's pleasure.
Thoroughly educational, and I think for the next webinar, hopefully we'll be back. So I've just been standing in. My name is Ian Bradbury. I should have introduced myself at the beginning, but I didn't. So I'm an optometrist, and I work in community and work in a hospital as well. Hopefully we've got enough results from the poll there. Hopefully you've all answered. So thank you very much for attending tonight and for participating in the poll as well. It's been a really enjoyable webinar. So thank you very much, Rabia.
Thank you very much, Ian. Thank you very much for standing for Purvi, and thank you very much everyone who has attended today, and look forward to doing more webinars soon.
Yes, I'd like to just say, thank you for joining us tonight. If you're a new person, welcome. And if you're regular, I hope I've not sort of let Purvi down, but it's been an enjoyable evening. I think I've learned a lot. So thank you, Rabia.
Thank you.
Again.
Thank you. Pleasure.
Thank you all for joining us tonight, and hope you'll join us on our next webinar.
Thank you. Pleasure. Bye-bye.
Take care, all. Bye-bye.
Thank you. Bye-bye.